Saint Lucia, mama, that's the land of my birth. Welcome.
You are live, by the way. Good morning. This is what I actually have to be watching behind the scenes usually. When you guys see me standing here laughing, it's because he's doing that off screen. And so today you guys get the pleasure of witnessing him do that on screen. Hi, good morning. So we're just gonna wait for a couple of more minutes for people to hop in. And as always, you can listen to my music while we wait and watch my husband dance apparently while we wait. Let's see, I don't have my watch this morning on. Alright, it is 10:02 and we'll get started. So we're just gonna turn our music down. Bonjour tout le monde, jodi a c'est vendredi et puis ita pour Rum Shop Talks. Good morning everyone, it is Friday morning, 10 a.m. and it is time for another episode of Rum Shop Talks. So we have something very exciting planned for you. Well, I think it's exciting, but that might just be because I'm a bit of a nerd. And so my husband will be joining us today. We will be talking about Advanced Health Care Directives, how they function in a hospital. It's such a big fear for my clients, and I figured it would be a topic that'd be interesting to the viewers as well. So, as you guys all know, we usually start our Rum Shop with a culture piece. And today we are talking about Campari. And you know, most of you guys, I know, well, not most of you, I've had a lot of people tell me that the reason why they watch my Rum Shop is for rum knowledge. So I bought this about 2 years ago because it is a staple in almost every Caribbean person's bar. However, during the times when you don't care what you drink, I never liked Campari, so of course I have no idea how to drink it. I made this absolutely terrible Pepto-Bismol concoction yesterday because we were gonna like actually show this. It was like Campari and condensed milk, and it tasted absolutely awful. And one of the things I found out is, first of all, Campari is from Italy, and that St. Lucia consumers of Campari around the world. That's very interesting to me because it's like, how the hell did Campari get from Italy to St. Lucia and have St. Lucia be like, you know, one of the biggest consumers? So today's culture piece, I actually am gonna ask you guys for a favor. For you guys out there who have great Campari recipes, who love Campari, I would absolutely appreciate you sharing your recipes with me. So comment below with your favorite ways of drinking Campari. Tessa said bonjour.
Bonjour.
And we will be trying it out in the kitchen, and your recipe might actually make it onto Rum Shop Talk. So, and of course you'll get credit for whoever's recipe that we decide to share. So please share your Campari recipes with me so I know how to drink this stuff. Because I want to join the group of St. Lucians who love Campari too. All right, so we are gonna dive right into our legal part today. And like I mentioned, good morning, Floriana, good morning, Tess. We will be talking about Advanced Health Care Directives. So for you guys who don't know, this is my husband, John. He is a registered nurse. He works at UCSD La Jolla in the cardiovascular ICU. So he is someone that I believe, well, from the conversations that we have, has a lot of experience with the practicalities of how Advanced Health Care Directives work in a medical setting. And for, like I mentioned, for a lot of my clients, they are concerned about their agents being able to just pull the plug. You know, we all hear about pull the plug, right? And so I figured that we would have John share with us how Advanced Health Care Directives actually work in a hospital, maybe dispel some of the fears and the myths that people have about them. So we'll get started. Hey Lou, good morning. So John, why don't you tell us a little bit about yourself, and then we can dive into your experience with Advanced Health Care Directives.
Okay, thanks for the introduction, Jan. It's true that I am an ICU nurse and have been for about the past 12 years, and that's my profession. And I do work with a lot of patients when they're in critical illness, and that's usually the time, or it's one of the times, when an advanced directive is pulled out and discussed. I am familiar with kind of how it plays out in the real world, how the advanced directive actually comes into play in the medical setting. But before we jump into that, I just want to do a quick shout out to Martin, Tessa's husband. He introduced me to Campari a couple years ago at a Caribbean graduation party in New York, and like you said, we just took it in shots. Martin showed up with a bottle of Campari. He was riding a bike, and all of a sudden we polished off the whole bottle. So I have only positive things to say about it. We didn't mix it with anything, but I would be interested to know in how else you could use it too. So here's to you, Martin.
And hi, Nigel. Good morning. Go ahead. Okay, so first question. When you see, when do you typically see Advanced Health Care Directives being discussed in your on your floor in ICU?
Sure. So the first time that an Advanced Health Care Directive should be discussed is by the ER docs or the ER medical team when a person first comes into the hospital, and that's when it should be brought up first. When a clerk in the ER or the admissions person, is a standardized question that they always ask: do you have an advanced directive? Do you have a copy with you? If you don't, what does it say? If you don't, would you like to create one now? That's the most appropriate time to start the discussion of what you would want your end of life to look like in the medical setting. It also comes into play in my unit. We do two different things essentially that are related to the advanced directive. Number one is when you have a surgery or a planned procedure, like you're coming in to get some stents placed, or you're coming in for a planned coronary artery bypass graft or open heart surgery or transplant, something like that. In that setting, you suspend. The doctor will discuss prior to the operation to suspend the advanced directive for a certain amount of time and make you what's called a full code, meaning everything is done no matter what, for a certain amount of time after the surgery. Assuming that it goes right, then after your surgery you can reinstate your advanced directive and make any decisions what you want. So that's one situation. The other situation is at a time of, so I guess medical futility would be the best way to put it. A person comes in critically ill, whether it's an infection or organ failure, that person, we're working hard to try to get them better, but things just aren't moving in the right direction. That would be a time when it's brought up again and discussed of kind of looking to clarify what's in it. So those would be the two most often times
Okay.
that would be that it would actually come into play.
Okay. So why would, at the time when a person comes in for a planned procedure, why would the doctor ask them to suspend their directive?
Because the procedure itself, the recovery from the procedure itself, almost always requires what's called life-sustaining treatment.
Okay.
Ventilators, anyone that goes into a major surgery like open heart surgery or a transplant is placed on a ventilator, and they're not taken off the ventilator until after the surgery at some point. There also, we do things in the ICU to support the organs, whether they're transplanted organs or whether they're repaired organs. We do things that would fall under the heroic measures as standard procedure
Okay.
to support the organs after the surgery during the recovery phase.
Okay. So if you have a directive in place and it's not suspended, that can actually be a detriment to your recovery from whatever the procedure that you're on.
Definitely.
Okay. All right. So one of the things that, like I mentioned, one of the things that clients have a hard time with is they're so concerned about, I go to the hospital and I'm in there for something that is absolutely treatable, and because I have this directive that says no to prolonging my life, that I'm gonna be treated with different care, and that I might not recover from something that is recoverable because of this document. What would you say about that? That fear. How does that? How does the medical profession treat directives in a situation like that can allay people's fears?
Right. So yeah, just to clarify, what you're asking is that if somebody has a do not resuscitate order on their advance directive, and they come into the hospital and they're ill or they're in need of surgery or something like that, and they're in the recovery phase, are they going to be treated the same as somebody who comes in and has an advance directive that says do everything no matter what?
Yeah.
Okay. So yeah, and that is an issue. I think that it's it shouldn't be an issue at
Okay.
all, because whether you have do not resuscitate or full code or full care on your advance directive, either way you're going to receive everything when you come in. Nobody will bring up that Advanced Health Care Directive and at a time when it's inappropriate. So if you look like you're getting better and it's clear that you want to live, that you would receive the same care. But in the hospital, to clarify that issue, we've created some new terminology.
Okay.
This new terminology has been to try to get away from that DNR thing.
Okay.
What the DNR suggests is do not resuscitate. And everybody thinks immediately of pull the plug, right?
Yep.
Or they think of, do I give CPR to this person or do I not do CPR to this person? Right? So those are other questions, but to get away from that, we've created new terminology. One of the terms is DNR full care, just to clarify that we're not going to resuscitate this person should they stop breathing or their heart stop. But during all the other things that we do while they're alive, we are going to continue to give full care.
Okay.
So it's just an extra clause to allay that fear that people are going to be treated differently. The other piece of terminology that we're now using is called an AND. And an AND stands for Allow Natural Death. And that's supposed to give a different perspective or a different approach to the DNR. So less pulling the plug and more recognizing when somebody's natural death is occurring and respecting that.
Okay.
Usually those things are not like acute issues, like a pneumonia that causes you to stop breathing. That kind of thing would be not your time of natural death, hopefully. That would be a recoverable event.
Okay.
That would mean that even if you have an allowed natural death or a DNR, that the assumption would be that this is recoverable. You could come in, we may have to place you on a ventilator for a while you get antibiotics and rest and your lungs recover and you can get better. So the allow natural death recognizes that that's probably, you're only 60 years old, say, at that time when you get the bad pneumonia. So it's recoverable. So that would not be the time of your natural death. Also what the AND order does, the allow natural death, is it also takes the emphasis off the pulling the plug and puts the emphasis back on, like, if this is the time of your natural death, to respect that, let you die with dignity, and just pass away naturally.
Okay. And would you say that this new terminology that the hospital have, or the medical professional have come up with, that it helps families, how does that help families with the decision that, you know, they're typically placed in the position of making with regard to the passing of a loved one?
Yeah, it's tough, and any of these things are really just starting points for the conversation that's going to happen when it actually is time for it to play out.
Okay.
Time of medical futility is definitely the time when we at the hospital, the medical team, and the family involved are all reaching a point where we're saying that no matter what we do, no matter what we offer or try or attempt, that the outcome looks like it's going to be the same.
Okay.
That this person is going to pass away. And then how do you want this person's passing to look? Do you want it to look like a whole team of people surrounding the person in an emergency situation, pumping them full of medication, and doing CPR, and putting tubes down their throat to help them, put them on a ventilator and help them breathe? Or do you want it to look like a peaceful place where people can say their goodbyes, where people can gather together and discuss things and, hopefully make it a better experience for the person? So the terminology, to answer your question, and the approach to it is changing all the time to help that conversation happen, so that we can allow people to die the way they want to.
Okay. I know that a lot of the forms that I deal with have very standardized language in it. It's like choice to prolong or choice not to prolong life, and that sometimes just seems so final, for a lot of people, especially now that we've been recommending that our young adults. So when a person turns 18, their parents can no longer access their medical information, no longer have the right to access that medical information or to receive that information. And the more I speak to parents, they're beginning to realize, usually in an emergency setting, that is the case. And as we're recommending directives for those people who, God, you remember when you guys were 18, you have not quite lived yet. You don't even know what life looks like, and you're being asked to make the choice to or not to prolong life. What would you say to, thanks for your question, Lou. We'll address it right after this. What would you say to those parents, or to help guide that conversation so that it is not so scary?
Okay, so 18-year-old or young adult,
Yeah.
having to fill out these forms, am I signing my life away by saying I don't want resuscitation? Am I risking being put on life support in a vegetative state by saying, I want everything done. Yeah, so when you're at that stage of life, you're not supposed to be thinking about these things. It's these documents and stuff like that, for the most part, are meant to guide decisions when people are at the end of their life.
Of course,
right?
yeah.
So you don't want that, obviously. One thing that I want to remind people of with these documents is that nothing that you put in the document is set in stone. Any of these documents can be, and your decisions can be changed at any time, throughout the hospitalization, throughout your lifetime, when it's appropriate. These are all fluid documents. They're just meant to give guidance as to your wishes if you were ever incapacitated and you weren't able to make these decisions for yourself as they come along. They're meant to give guidance for your loved ones, for your family members, for the person that you named in that document to be able to act on your behalf. That's what they're meant for. And one thing that I want to remind young people of is that no matter what you put on that document, as long as the assumption is that you want to live, which is the assumption for everybody unless you've come in after a suicide attempt, that you want to live.
Yeah.
And the medical team will, no matter what it says in your advance directive, do everything possible to save your life if you're a healthy young adult. And no matter what it says on there, that you're going to get everything possible.
Seems like we might have I don't know if we lost you guys a little bit here. Lou had a question. What is the percentage of people that survive being on a ventilator? Standard procedures versus COVID cases.
Okay, so I don't have, Lou, in answer to your question, I don't have any specific statistics on this exact subject. But I think that part of it that I may be able to help with is that, and I think for as far as the COVID ones, I think that would probably be an easily researched number. I think we could probably look that up, and maybe we could get one of our staff here to help us out.
Yeah, we have staff.
Dimitri, how many people that are placed on a ventilator for COVID-19 get off the ventilator? So we're looking up that, Lou. But also, the other group that standard procedures, that category, it really depends. I mean, it really depends on your ability to heal. If you're a person who has lung issues, known lung failure, that's progressing, that your chances, depending on where you are in that, are going to be worse, obviously, if your native lungs are not good enough to, if you're just borderline, just hanging in there anyway. So it would really be a case-by-case person. If somebody is, say, 60 years old and otherwise healthy and gets a bad pneumonia or a bad virus and is placed on a ventilator while they rest and heal, then you would have a very good chance of, or you're otherwise strong, would have a very good chance of getting off the ventilator. So it really comes into, the question would be, what's your shape going into this? What kind of condition are you in going into this? If you're somebody who's strong and has good lungs, there should be no reason why you can't get back off the ventilator.
Okay. And this is kind of off the topic of Advanced Health Care Directives, but just because we're talking about ventilators and trying to address Lou's question, I've heard that the longer you're on a ventilator, the harder it is for you to get off.
Yeah.
And that there's a window within which they let you be on a ventilator, and then they've got to either take you off or agree that that's kind of
Right.
where it's at, and either you're taken off to allow you to be able to breathe naturally on your own, or you can't, and then that's the end of your life. What's that timeline? I can't remember what it is.
So we'll use two different pieces of terminology here. One will be the endotracheal tube, and that's when a person has the tube placed down their trachea, and that's meant to be temporary. And a person can keep the endotracheal tube in for a standardized number, give or take, of 14 days. So the expectation that when an endotracheal tube is put in is that sometime less than 14 days, we're going to be able to get them back off the ventilator.
Mm-hmm.
At that 14-day mark is a big decision, because then you have to either decide to remove the ventilator and let the person pass naturally, or hopefully make it, or you have to put in a tracheostomy, which is when they open up your trachea through the outside of your throat and place a trach tube in, and then continue on the ventilator and hopefully be able to recover after that.
Okay. So even at that point, there's still a chance that you could recover
Oh, sure.
if they do the trach. Okay.
Yeah.
All right. So we got some stats here for you, Lou, about the COVID recoveries.
So a little disclaimer that the numbers aren't nailed down yet, but 50 to 75% of COVID patients that are placed on a ventilator recover. They are able to get off the ventilator.
And one of the things that we've been doing here at the law office of John Meyer is with our directives, we're actually making sure that we put language in the directives. So, a lot of clients are choosing not to prolong life, and we're making sure that in the Advanced Health Care Directive, you still continue to receive ventilator care if needed in a situation such as COVID. So making sure that's covered, and it's great to see such a high rate of recovery for someone who's placed on the ventilator with COVID. So with regard to decisions, sometimes clients come in and they have very explicit instructions that they want to put in the Advanced Health Care Directives about their care, and I have to remind them that, number one, I'm a lawyer, not a medical profession, so I don't do that, and that we actually do use a standard form for our Advanced Health Care Directives, so that there is God, I can't say that word. Standardization. There we go.
Where's the Campari?
I know. I probably need to try to compare it to get me to be able to say that word. Standardization across the board, no matter where you go with your Advanced Health Care Directive that comes from our office. But with people that have very specific wishes, when is the time, and where is there a document where they can actually have those wishes shared?
Yeah. So when you're in the lawyer's office, or you're filling out an advance directive on your own, don't get too into the specifics, in my opinion. It's a general, the Advanced Health Care Directive is just a general guideline. It's a start of the conversation that's actually going to happen in the hospital.
Mm-hmm.
And when a person gets to the hospital, we have another form, which is very specific, and it is filled out with a doctor and has check boxes for everything that we can foresee could happen to you.
Mm-hmm.
And we go through section by section through that form, and a doctor signs it and you sign it. And so that is called a POLST form,
Okay.
which is an acronym for Physician's Order for Life-Sustaining Treatment. It's sometimes called a MOLST, but it's typically called a POLST form,
Mm-hmm.
Physician's Order for Life-Sustaining Treatment. And what that does is it handles all the specifics.
Okay.
So if you're in the lawyer's office or you're outside the hospital somewhere, don't worry about all the little things. Put in the things that you want to put in. That's totally fine to change it. Definitely name somebody that is going to be your agent.
Yeah. Okay. So I like that disclaimer. I love that disclaimer. So for any of you guys watching who are thinking about getting your Advanced Health Care Directives done, don't go into the specifics, because you know there's a different form for that, for someone who actually knows what they're doing and what they're talking about. So for young people though, so I feel like the polls is something that you might seem more appropriate for, like, you know, someone kind of later in life, right?
Sure.
For young people who, when they end up in an emergency, when they end up in, you know, an ICU, typically are there because of an emergency situation, you know, an accident, fall. I think about, whenever I think about Advanced Health Care Directives, I think about Terry Schiavo. She was young, you know, and probably never really had a conversation, and everyone was like, well, if she had a directive, you know, that would have solved the problem. But her directive probably didn't have even if she had had one, it wouldn't have had very explicit instructions, and she probably wouldn't have had a pulse. So in a situation like that, what would you recommend for young people who might not necessarily be at the point of pulse, but need to have these decisions or have thoughts on these decisions, like, you know, fleshed out? Where is the appropriate place for them to have that?
I think that the most important place for young people to have that discussion is with their loved ones. In that Terry Schiavo case, was it going to be the parents who got to make the decision, or was it going to be the husband who got to make the decision? So naming the agent is very important, and the specifics of what you want and how you see that going. If you tell the person that you've named to be your agent, or every other member of your family who think might be involved in the situation, should it come up, if you tell them how you feel about this, that is the most appropriate way to handle it. One thing that I'd like to include in that is that you're right, the post form is a later in life thing. The post form starts when a person comes in critically ill and it doesn't look good. So if your 18-year-old comes in and, you know, broke their ankle, the doctor's not going to fill out a post form. But if grandma comes in with a bad pneumonia at 65 years old, then there's a good chance that a post form is going to be filled out. That post form will only exist while the patient is being treated for that issue.
Okay.
Right?
Okay.
So, but it doesn't end at the hospital all the time. So if a person comes in, grandma, she comes in, she's got a bad pneumonia, she needs to be placed on a ventilator, she's still awake and discussing, her husband's there, and he's the named agent. We're creating this post form before we put her on the ventilator if there's time, and then she exceeds that 14-day mark. She wasn't strong enough to get back off the ventilator, or didn't heal completely in that 14-day window, and now she needs a trach, and she needs to be sent to a nursing home. That post form will follow her into the nursing home. And, you know, hopefully or the subacute care facility, I shouldn't say nursing home, said something different, but the subacute facility, so she can continue on that same trajectory with that. So I just wanted to mention that.
All right, I think that's an important point to make, that it's not just at a hospital, but, you know, it kind of follows you along with your care. So I like what John just said, and I wanted to kind of just emphasize that, you know, for us, especially when we're doing these directives, we do make a point of encouraging clients to have conversations. You know, we live in a society where people are so afraid of speaking about death and considering death and thinking about death. But based on what John just shared with us, and what we've seen happen, you know, failure to have those conversations actually puts your family in a very difficult position. You know, the last thing you want is to have a Terry Schiavo situation where you're in court for years battling with family about what to do about a person's life, but sometimes that's what happens. Like family members are fighting about what to do because you, the family member, did not educate your other family members, your loved ones, your agents about what you want to do. So in as much as it's an uncomfortable conversation to have, it is a worthy conversation to have, right?
Definitely.
Yeah. And as you can tell, we have those conversations a lot. So he knows exactly what I hope you do know exactly what I would like to have happen.
What would you like to have happen?
I don't know, pull the plug. I'm like everyone else. I don't know. I think that if there's a quality of life that, and for me, quality of life, and I think for a lot of people, quality of life is a subjective thing. Quality of life for you might be being able to run. Quality of life for me is not running because I don't like to run, but being able to communicate and think and being able to like be independent, I think would be what I define as quality of life. Being able to get up and do as I wish and drive and do all that stuff, and definitely have that cognitive awareness is super, super important for me. So if I'm not gonna be able to get that back, I think I'd rather not be here. Yeah. So as you see how easy that was, an easy conversation. It can be emotional, but not necessarily have to be. At this point, we want to just see if anyone has any questions, questions that they want to ask about Advanced Health Care Directives to John while he's still here. If you don't want to ask your questions, that's all right. You can put them in the comments, and he sees them because he's on my Facebook, so we can address your comments there as well. Hopefully you found this very helpful. For me, every time I have a conversation with John about Advanced Health Care Directives, how they work in a hospital setting, I'm constantly having those conversations because I have to talk to clients and I have to answer questions which I'm not equipped to answer. They don't teach us that stuff in law school. They just teach us how to draft the documents, not necessarily how to address and answer them. That's okay, Mama, welcome. So if you have any questions, please feel free to ask them. Like I said, we know that this is difficult conversations to have, but so worthy. If you don't have an Advanced Health Care Directive, please go out and get one done today. Almost every state out there has a statutory form on the books that you can download and use. Make sure it's executed properly, meaning that the documents should give you the option to either get them witnessed by 2 witnesses over the age of 18, or have it signed in front of a notary and notarized. So make sure that if you're going to do your own Advanced Health Care Directive, that it is being executed properly, because you want to make sure it works when you need it. And for any of my California, Southern Orange County, but definitely California viewers out there, we are here to help you with your directives. We make those very easy. And for all my parents with kids who are 18 or turning 18, now's the time to start having that conversation with them. You want to be able to make sure that you can continue to care for them in the way that you're used to doing. We are offering a package. It's $300 where we provide your 18-year-olds or your college-aged kids with a power of attorney, Advanced Health Care Directive, HIPAA waivers, and a FERPA waiver for accessing education in a pretty low package for $300. So if you're interested, definitely reach out and we'll get you started. I want to thank John for stopping his projects and for being here and for sharing his knowledge and experience with us. It is always great having people with experience in other areas. That's not my forte. Talking to you guys and sharing it with you. If there's anything else that you would like to know, please reach out. We're happy to educate you. The more you know, the better you can advocate for yourselves. So on that note, we see no questions coming in. We will thank you for stopping in for another episode of Rum Shop Talks. Hope you found it educational, and we'll see you next week for another episode of Rum Shop Talks. Bye, and your Campari recipes, people, help me out here. Where is it?
I think she's